connect with people in many different ways. So good morning, morena everybody. I am Trina Cooper. I'm the General Manager for Popup. Thanks so much for making the time this morning. This is our 9th part of Pop-Up Chat, and today we're talking about the role of the GP in perinatal mental health. Housekeeping is the session will be recorded and made available on YouTube. Please note that your video image may be seen when we share the presentation on our website and social media, so just ensure that you have your camera turned off. And we ask that you remain muted as well. To ask a question, you'll have the chat function at the bottom of your screen. So if you want to ask a question, just type it in, and if it's relevant to the slide that Rona's talking about, then I'll interrupt her. Otherwise, we'll go through all the questions at the end of the presentation. Next week, our pop-up chat is with Sarah and Lucia from the Te Menino Trust based in Porirua, and they're talking about the Pacifica Initiative for Pregnant Mothers. So we'll send out details about that one as well. I'm going to hand over to Dr. Rona Carroll. Rona is a GP based here in Wellington, and she's also a representative on our Popup board. So Rona, I'll hand over to you.
Thank you, Trina, and thanks for joining this morning. It's good to see some of you here. So as Trina said, I'm a GP in Wellington. I've got a particular interest in the area of perinatal mental health and just general parenting support and breastfeeding medicine as well. That was kind of my way into this area, was through doing breastfeeding support, and as you all know, such close links between the two, and that's how I became interested in the mental health aspect as well. I was lucky enough to have some experience working at the CCDHB Specialist Maternal Mental Health Service. I worked there for 6 months as a GP in the service, which was really interesting and gave me a lot of extra experience. So I'm going to talk today about just about general practice and GPs in this area. So a bit about when you might think about using them and what the GP can do, because I know you all, I'm sure you suggest that people should see their GP if you're worried about them, but sometimes it can feel a bit like where the parent might think, well, what's the point, or what can they do? And I guess I want to sort of highlight that we can do a lot more than write a prescription for medication. So let's go through these slides. Oh, why is it not moving? Hang on. Oh, there we go. Okay. So one of the points I want to make is how important collaboration and communication is when you're caring for someone, especially someone who you might be worried about, someone during pregnancy or postnatally. When things go wrong and people look at cases, one of the common themes that always comes through is that sort of fragmentation and loss of continuity, and people not talking to each other and having different people involved who, everybody can hold one piece of a jigsaw and not talk to each other and put it together. So just remember, that it can be really helpful to talk to each other. The GP might have a lot of information about somebody. You've got a lot of information, and sort of talking to each other about your concerns is a good idea, and working together to care for people. So before I go into the sort of role of the GP, I just thought it's worth doing a little bit of background about why this is even important. We know that pregnancy and the postnatal period are, they're not protective against mental illness at all, and in fact it's quite a high risk time. So in terms of depression, we know that around 12% of women experience depression during pregnancy and about 20% postnatally. And I've just sort of highlighted the antenatal there to remind everyone that this, I think we're better now at talking about the wider definitions, but certainly people used to always just use the expression PND or postnatal depression, when in fact having mental health difficulties during pregnancy is extremely common as well. And we mustn't forget that it's not something that magically starts when your baby's born. And those stats are for depression, but just to point out that anxiety is just as common as depression, and there's a lot more happening than just depression. And then you can see from the second point, unfortunately, there are higher rates of depression in certain groups, such as Maori women, Pacifica women, young parents, and very high in Asian women. And if you look at the Pacific rates there, under 25-year-olds rises to 30% of people being depressed in the third trimester of their pregnancy, which is quite huge, really. And then, you know, mustn't forget about partners as well. This statistic is about fathers, about 10% of fathers experiencing postpartum depression, but of course not all partners are fathers. And it's a bi-directional risk there. If one of the partners has depression, then there's a higher risk of their partner having it. So we've got to remember the whole family when we're doing this. And obviously it's, you know, not nice to experience mental health issues, but there's a huge number of various risks that untreated depression, anxiety, and other mental health issues can cause. And it's just really important to keep that in mind, to think about the bigger picture of why this is so important. Of course, a reduced quality of life for the person who's suffering the distress, with a higher risk of self-harm and suicide. And in fact, in New Zealand, suicide is the leading cause of maternal mortality, which is, you know, a pretty shocking statistic. It leads to increased risk of smoking, drug and alcohol use. And not everyone knows that antenatal depression is associated with a number of obstetric complications and potential problems for the baby. There seems to be a link with the higher stress hormones and cortisol levels affecting the baby. And there's higher rates of premature delivery, low birth weight, and other complications. And then, of course, there's the impact on the mother and infant bonding and the relationship. You know, babies need a well parent who can be emotionally available for them. And if you're struggling and suffering yourself with distress and difficult emotions, it's hard to really be that person for your baby all the time. So that can also sadly contribute to negative outcomes later in life and poor development for the infant. And then, as we've mentioned, the wider family, the impact on the partner, the stress that can cause in relationships. And depression and anxiety can also lead to more likely to have breastfeeding difficulties as well. So it's obviously hugely important for so many reasons that we get this right. And I like this quote just to remember that we're talking about two people here. You know, whether if the mum is unwell, it's not just a mum on their own. If the baby's not well, it's not just a baby. It's the whole dyad and the relationship between the two. And this quote from Donald Winnicott, who is a well-known researcher in this area: "There's no such thing as a baby. If you set out to describe a baby, you'll find that you're describing a baby and someone. A baby cannot exist alone, but is essentially part of a relationship." So when we're thinking about this whole area, we've got to keep the two in mind, the dyad. So a little bit about GPs and primary health care. Obviously not everybody knows their GP well or goes to see their GP very much, and that's okay, but some people really do. And some people have had the same GP for a long time, who has a good understanding of not just their health issues, but their social situation as well, their family members. The GP might care for the partner, the other relatives, might look after the other children. You know, it really can have that holistic kind of whole family kind of continuity overview, which is really a really valuable thing when other people may just be seeing one snapshot of somebody's health and life. GPs have got good knowledge of the other services in their area and different community supports that are available. And I'm sure everybody who works with parents will have good connections and know probably know better than the GPs what supports there are out there. But there might be something different that one of you didn't know and how to access, and it can be a good source of knowledge for that as well. And the GP, I think, is a really good central point for connecting all the different services and people involved in somebody's care. So like we talked about, that communication on that risk of fragmentation of care. You might have somebody who sees their midwife, and then they have a well child nurse. They might take the baby to the pediatrician. They might see a psychologist or a psychiatrist or counsellor for themselves. There might be a social worker involved, all these different people, and the GP can be a good sort of, any sort of specialist letters or discharges from the hospital or anything like that. All that information comes to the GP, and they really hold a real central place of knowledge, really, of what's going on for that person, especially if people communicate and talk to each other. And yeah, just that whole thing about the different parts of the puzzle, where the pediatrician might just see this one snapshot of the baby not growing very well, but actually somebody else holds some information about the bonding difficulties and feeding difficulties that are going on, and it just all feeds in together. So I think the GP can be a really good central point there. And what I try and tell GPs as well is to use, you know, any opportunity, any appointment with a mother or baby is an opportunity to check in on their well-being. You know, it doesn't have to be an appointment for a mental health issue. Most of the time it's not. So GPs often have increased contact with their patients during this period of their life. They might be before becoming pregnant to discuss planning a pregnancy, especially if they're on medication. They might come when, often people come with their first positive pregnancy test to say, what do I do and how do I find a midwife? There might be issues during the pregnancy that they come in for. Everybody will come in, you know, mostly to their GP. Some go to the pediatrician, but for the 6-week check for the baby. And while that is for the baby, it's a, you know, one of the roles of the GP at that time really is to check in on mum and see how things are going. You know, I really strongly believe we need funding to do a funded 6-week check for all mothers, and that's something I will keep pushing for. And then there's opportunistic, you know, times at other presentations. So contraception, for example, you know, it might take 2 minutes to sort out their contraception, and then you've got a bit more time to check in with how are you going and that kind of thing. Or parents might come in just for their children or just for their baby, and actually the baby might be fine, and the main problem you can tell really is the parents, and that can be a good opportunity to do that. Yeah. So lots of times when it can happen. So reasons you might suggest somebody go see their GP. So everybody who has a past history of mental illness, especially if they've had a severe illness, needs to see a GP if they're pregnant. If someone's on medication for mental health, you know, good to see the GP to check in about that. A family history of severe mental illness is a big risk factor, particularly if there's bipolar disorder and a first-degree relative. They should, you know, be seen by a doctor as well, because that's a high risk. Obviously, if you've got concerns about someone's mental health, you might suggest they go to their GP. Worried, if you know, low mood, someone who's worrying a lot, crying a lot, struggling with sleep, or just seems really stressed and or a really flat mood. Or if you're concerned about the relationship with your baby. And it may be, you know, there's real close links, isn't there, with problems with the baby. We've mentioned breastfeeding is more likely to come into difficulty if there's perinatal mental health issues. There might be more, well, really a baby who's crying a lot, that can be a sort of bi-directional as well. It's very stressful to have a baby who cries a lot, but also being very stressed about it can sort of make it worse in some ways, and that's a very difficult situation. Or sleep issues, you know, if sometimes parents will really struggle to get back to sleep after their baby's gone back to sleep and get very stressed and worried about their sleep. And then there's other risk factors as well on this next. So most of these we've covered. I'll just point out a couple of them that we haven't. History of trauma or abuse, that's a big one. So, you know, somebody may have had experienced a sexual assault or childhood abuse, and they may be doing fine, but pregnancy and the postnatal period, having a baby can be very triggering and could bring up a lot of stuff that they weren't expecting. So I think that's someone to really flag in your head as someone at risk. Also people who have difficulties around birth, obviously birth trauma or premature babies or health issues in the baby, that's a higher risk. And people where there's a lot of socioeconomic adversity and social chaos, drug and alcohol issues is obviously a higher risk. And unplanned pregnancy is as well. There's an increased risk of depression in the first trimester for those people. And teenage pregnancy would be one to have on your radar as well. And pregnancy loss. So if you are involved in somebody early in their pregnancy and are with them through a pregnancy loss, you know, 20% develop persistent symptoms of depression or anxiety. It's definitely an important risk factor, and you'd want to encourage them to see someone, whether it's a GP or a counsellor or someone, just to follow up and check in with how they're going. Now, there might be times when suggesting to someone, oh, you should just book a GP appointment isn't the right thing to do, and actually they need to be seen a bit more urgently. And hopefully you'll are aware of how to do that in your area. Every area will have a sort of 24-hour crisis mental health assessment number that anybody can phone. You don't have to be a referrer. A family member can phone if they're worried about someone. And some of those reasons why you might arrange a more urgent review would include suicidal ideation or thoughts of harm to the baby. Obviously, any suicide attempts, psychotic symptoms. So postnatal psychosis is rare, but is a psychiatric emergency. Sometimes that can present with sort of experiences that don't match reality. So maybe seeing or hearing things that aren't there, or having beliefs that don't fit with reality, like thinking that there's somebody out to get you, or your baby's evil and trying to get you, and it can often be linked with maybe needing the need for less sleep and just staying awake all night and being full of energy and thinking you might have extra powers. There's all sorts of different ways that can present. Hopefully it will be kind of obvious and a bit and strike concern, and that will be definitely need an urgent same-day assessment. And if there's really significant fluctuations and change in someone's mental state, or really a lot of hopelessness, feeling very inadequate, feeling very disconnected from baby, those people may not get a same-day appointment, but they certainly would need something, you know, fairly urgent and warrant a discussion with the mental health service. And you know, most areas have a perinatal mental health service, so you could always speak to them for advice as well. They usually always have somebody a duty person who carries a phone, and you could phone and say, what do you think I should do? So when they do go in to see the GP, they, you know, hopefully the GP may already have a relationship with them if it's somebody who has other health issues or someone who they know already. So that makes things a bit easier. And the GP, one of the advantages, I think, is just the opportunity to get a good assessment with someone who has that wider understanding of the health of the mother, the health of the baby, and understands mental health. And so, you know, if you can tell something isn't right, but you don't really know how bad it is or not, you know, it's a really great opportunity just to get that really good assessment. Not everything will be covered that's here in every GP appointment. You know, I really am aware that not all GPs are the same, and people will have different experiences depending on their GP. Some GPs are very interested in this area and very good at it, and others may have less knowledge. But every GP is very used to dealing with mental health issues and doing assessment and assessing for risk, and, you know, making a plan around that. And if a parent sees a GP and feels they haven't really got much out of it, or the person didn't really understand, they could go and see somebody else. You know, it's not always going to work out with everyone. And this is one of the reasons why PADA really, you know, we work to educate GPs and raise awareness in GPs, because we feel this is such an important area for GPs to have a really good understanding of. So the assessment would include sort of looking at the psychosocial situation, you know, who are their supports, who they're living with. Are there any other stresses like housing stress, money stress? Thinking about that sort of past history of risk factors. GP may know that they have had a previous history of assault or abuse, for example, which the parent may not have disclosed to you, or the other way around. They might tell you about it and not their GP. The GP may have information about previous miscarriages or terminations, which are impacting on how they're feeling at the presentation. They should know about past mental illness and how severe that's been, and medications around that. And then they can do an assessment of their mental health. So really sort of looking at severity and sort of diagnostic things, which I'll mention in a minute. And just to really help figure out what the best plan is going to be. Someone really needs to talk to the parent to understand, or we often categorize things into mild to moderate and moderate to severe, and they have different kind of treatment approaches. So that would be, I think, the most useful thing. And then, of course, looking at what's happening with the baby. You know, there might be worries about the feeding, about the sleep, about the crying. And while GP appointments are far too short for things like this, at least they could make a plan. They could, you know, if there's a lot of worries about the baby's well-being, they can get the baby, you know, come back for another appointment with the baby to do a really good health check around that, or, you know, just kind of get that overall picture of what the worries and stresses are to make a plan around them. And of course, the GP can do a good risk assessment. So we've mentioned that suicide is the leading cause of maternal mortality. And it can be hard if you're not used to it to know how to assess that risk, and when it's you know, often people will have sort of fleeting thoughts, or just thoughts that pop into their head about not wanting to be here, or about, you know, sometimes it can be more specific things, but that doesn't necessarily mean that they're going to do anything to harm themselves. So it's important to have somebody who can do that risk assessment to really sort of see where that's at, and whether that needs some urgent help, or just close watching and reassurance. So one of the tools that we might use to do this assessment, GPs have a number of sort of questionnaires. So the GAD-7 is one around anxiety, the PHQ-9 is a depression one, and you've probably all heard of the Edinburgh Postnatal Depression Score, the EPDS, which is what this screenshot is of. Some of it's been cut off, but hopefully you've all seen it before. So it's asked the parent about how they felt over the last 7 days, and for each of the questions they tick a box, and then that gets scored with different questions having different sort of scoring methods to come up with a number. And it's a really good way of just getting, you know, without having to go into heaps of detailed questioning, just to get a really good idea of where things are at for the parent and how severe things are. So that can help as part of that assessment in considering whether somebody's mild, moderate or severe. Yeah, that can be done during pregnancy as well. And hopefully most GPs would use that. And then after that, they, as well as making a sort of plan around where to next, there'll be sort of consideration about any diagnosis. Now, not everybody, of course, has a diagnosis or a label, and that's not necessarily a helpful thing to do. And the vast majority of people will be experiencing more of an adjustment, a normal adjustment, or possibly an adjustment disorder, if you want to call it, give it a label. You know, as you'll know, working with parents, this time is a huge period of adjustment, and it's very normal to struggle with that and to find it difficult and to cry more and to be exhausted and to feel like you're not good enough. But there is that difference between when that sort of tips over into something more concerning and more pervasive than simple adjustment. And again, I think this is an area where GPs, you know, some GPs possibly need some more education. When I worked at the maternal mental health service, we did see quite a few referrals where someone was fairly soon after their you know, after having the baby, presented to the GP tearful and struggling. And it had sort of appeared that they were just given a prescription for antidepressants and referred to maternal mental health. So that's obviously not necessarily ideal, depending on what the severity assessment was. The maternal mental health service, the specialist service, is really there for that sort of more that tip of the mountain, you know, in terms of the severity, the really moderate to severe and particularly severely unwell people. And most people who we see fall into that other group, the mild to moderate, where the specialist services really aren't the right place for them. And you know, there's absolutely a gap there of where is the right place to help them, and the different places have better services and community supports available to them. It's definitely a gap. But sometimes, you know, as you know, working with parents, things change a lot, and those early weeks are particularly intense and full on. And you, when you're looking at the picture from the outside, you know that in a few weeks or months things are going to feel very different for them. But it might be a matter of just putting in lots of support until that happens. So we've mentioned depression, anxiety would be by far the most commonest mental illnesses to occur at this time. But there might be something else going on, and I think that's where it can be, you know, if you just feel like something's a bit different about it, or you're just not sure, that can be a time when it's really good to get that medical perspective. Some people have bipolar disorder, and that can sometimes just come out after pregnancy, after childbirth, can be almost a trigger for that sort of first manic episode. We've mentioned briefly psychosis, and then, you know, there's all sorts of other issues that people may have already before they go into pregnancy and childbirth. that can, you know, aren't just going to disappear during this time, and they're going to pop up and cause issues. And that could be a history of eating disorders. You know, that could be triggering with the body changing during this time. Post-traumatic stress disorder, we sort of mentioned past trauma. That's a really important one. And there's a number of other possibilities. So it's just worth somebody who knows about mental illness, if you're, you know, if somebody seems quite unwell, to be having that look at them. And then in terms of what the GP might do, now hopefully they won't just give people a prescription for antidepressants and tell them to be on their way. Hopefully there'll be a bit more of a holistic approach. So sometimes having reassurance and explanation, even though you've done that yourself, having it from someone else can sometimes just be really helpful and just really make that parent feel like, okay, this is a difficult time and what I'm experiencing is normal and it's going to be okay. And sometimes it helps having someone else say that. You know, sometimes when someone is feeling really overwhelmed, it might be that just removing or reducing one or two stressful bits of the picture can make a huge difference to how they feel. So they may be quite worried about their baby, for example. Why is the baby crying? Is there a health problem? And so to have the GP be able to just check over the baby and say, look, baby's perfect, you know, completely healthy, everything fine. That might be enough just to reduce a little bit of that stress and worry, to make everything else feel a bit more manageable. It might be financial, you know, maybe it's the GP can help by doing WINS paperwork and getting some things sorted out there that can reduce enough stress to make everything else a bit more manageable. While I'm mentioning finance, actually, I will just mention, obviously there's an issue in New Zealand that it costs to go and see a GP. I'm really lucky in that I've been working for many years now in places where people don't have to pay to come. So I'm very free to follow people up as frequently as I want and for as long as I want. And it's the way it should be for everybody, really, because it's really the best way to help people. But if you asking a parent to come back next week, we'll see how you're going. If that's going to cost them $40 or whatever it is, you know, that's a huge ask for most people. So I guess it's worth mentioning that there are different ways that GPs can fund some of these appointments. Like, I would hate to think that someone who was unwell and struggling would say, oh, I'm not going to my GP because I can't afford it. You know, I would encourage you to talk to the GP and see what options there are. During pregnancy, there are some appointments that they can get funding for through a pregnancy kind of payment thing. And if there's mental health issues, most of the primary health organisations have funding for extra mental health appointments. So you know, as we've said, you can't do all this properly in 15 minutes, which is what most GP appointments are. So hopefully, you know, ideally you do a sort of brief assessment, figure out what needs to happen, and then get them back for a longer appointment. So if you can tap into the mental health, you know, if the GP can tap into the mental health funding to do a longer appointment next time and make it free, that's ideal, really. And with WINS as well, if somebody's on a low income, they can the GP can fill in the paperwork for a disability allowance to help with the cost of health, GP consults, counselling, psychologists, medications. You know, there are ways around it. Sometimes it's a bit involved, jumping through a few hoops to get there, but it would be awful to think that would completely stop anyone getting help, because there are usually ways around it that GPs are aware of. So obviously the other parts of the plan might involve bringing in their other supports, their family. You know, the GP may have a relationship with that person's partner through being their GP, and might even, with the parents' permission, contact them and discuss with them, or they might be in the appointment and make a plan around that kind of support. There might be community supports, peer support, and community groups for them to link them in with. But like I say, I'm sure that you would be more aware of those, but there may just be something that they have heard of that you haven't. And they have access to, like I say, to get funding for counselling. So there might be free counselling that they can point them to, or they might be able to fill in the WINS counselling allowance form so that they can get that paid for by WINS. And sometimes medication will be part of the management, absolutely, but it's certainly not the only thing that GPs can do. And you know, medication, which I'll talk about a bit more in a second, is really only, you know, the evidence really backs it up more around that sort of moderate to severe end of unwellness. So people in that more mild to moderate group, Sometimes medication can help, but generally it's all the other things. It's going to be the support, the sleep, the eating well, the feeling, you know, getting out of the house, the counselling and therapy and all those other things, and time. There's only so much that a prescription can do. The GP is also obviously well placed to refer to any secondary services, whether that's paediatricians or psychiatry or anything like that. And they, you know, will often, you know, they can easily have links with them in terms of phoning them up for advice and having a chat with a psychiatrist potentially and things like that. And then hopefully they will arrange follow-up. So this is something I think is really important, and we've mentioned the financial worry about that, but really bringing them back soon for a longer appointment, you know, to keep going with some of these discussions and issues and how things are going in a week or two, really, really important. So just a little bit about medication. It's really important to remember that when people are thinking about medication, we're not just talking about what are the risks of medication for the mother and the baby against doing nothing. It's the risk of taking a medication against the risk of having untreated or severe mental illness on the mother and the baby. And as we've mentioned before, those are not, you know, those are not nothing. There's many risks to both mum and baby of being really unwell. And so it may be that the risk that far outweighs any tiny risk a medication might have. So those are the kind of things that we need to take into account. And if medication seems to be warranted, then in general, the benefits of medication outweigh any risks to mother or the baby or the fetus. And people who are already on medication, you know, sometimes people will be keen to stop them as soon as they realize they're pregnant because they think it might be harmful. And so it's really important that people don't rush into doing that, and absolutely go and discuss that with a doctor who knows what they're doing, because there's a relapse rate of 68% for women who stop their medication for depression, for major depressive disorder in the first trimester. It's a risky time, like we've discussed. And it may be that they're all right to come off their medication, but somebody needs to look at that situation and help make a good judgment of that. And it may be that reassuring them about the very tiny risks of their medication compared to the big risks of them relapsing and becoming unwell during pregnancy is the kind of discussion that needs to be had. Somebody may already be on medication, and it may be that needs to be adjusted. Or, you know, considering what the effects of that are during pregnancy and breastfeeding. And, you know, as I've sort of indicated, the majority of things are okay to keep taking, but there are a couple of exceptions where you absolutely should not take them when you're pregnant. So that's why people who have health issues and are on medications, ideally they would talk to their GP before they become pregnant to make a plan around that. And people who are on medication where you absolutely should not get pregnant would know that would be part of the discussion that someone's had when they prescribed it, so they should know if they're on a medication right now. You know, certainly in Wellington, where I'm based, the local perinatal psychiatrists are very available on the phone and happy for phone advice or electronic advice around medication questions. And certainly when I worked there, that was quite a big part of the job, was just communicating with GPs around medication advice, not necessarily needing to see the clients. So, in summary, I guess I just wanted to say that untreated perinatal mental health problems can have serious consequences for mum and baby and the rest of the family. It's really important for healthcare providers to communicate and collaborate and work together if you're worried about someone, rather than everybody working alone. There's a lot of reasons, hopefully, you can see to where a GP can be useful, and that's not just for prescribing medication. Involving the GP if you're worried. They might have other parts of that puzzle. And mental health problems can show up in many ways. And, you know, it may be that it's through the baby, and somebody might be going to see the GP because they're worried about some aspect of their baby's health, but you're worried about the mother. If that's the case, you know, that can be a really good way to get them to the doctor, because they're going for their baby, not for themselves. That would be a common thing, really. But it might be worth a phone call to the GP just to say, look, so-and-so is coming to see you because they're worried about baby, but actually, can you check in on mum because I'm really worried about them? And if the GP doesn't know, then they might not, you know, they may not ask or pick up on it, and they might just focus on the baby. And just remembering that the GP has those connections to other, you know, to access to funding and to other services in the community. That's me. And I finished with this picture, which I love, which my mother, who's an artist, made many years ago. This is me as a baby and my mum breastfeeding me.
Wow.
Thank you.
It's an amazing picture, Rona. That's beautiful.
It's gorgeous, eh?
Wow, that's really special to have. Thank you for sharing that with us. That's really lovely. Wow. Now we'll just jump back. There was a question from Katia, which I think refers back to one of your very, very first slides about the statistics for Maori and Pacific population during third trimester. Where did those statistics come from? Because she's struggling to find research in New Zealand around those groups. Have you got some?
Oh, cool. Yeah, I should be able to send you the link. Shall I send the reference to Trina maybe, and you can pass it on? Would that work?
Fantastic. Yeah, we'll include that when we do our mail out. If you're able to sort of send that to me today, then we can include that with the recording. Very useful. Thank you. From Yvonne, she says, not all general practices have access to funding for mental health at all. Cost re-follow-up is definitely a factor. We should advocate for direct Ministry of Health funding for this vulnerable group. Yes.
Yes, I agree. Absolutely. Yeah, that's sad to hear that not everybody has access to the extra mental health funding. You tend to just sort of know about the area you work in, obviously, and I know in Wellington we do. But yeah, absolutely. And I think even just, I know it's not enough, but even that 6-week check, if there was, you know, to do a baby's check in that time, but then to also, you know, check in with the mum is far too much. You need more time. There's not enough time for any of it.
Yeah. Yvonne, do you want to unmute and comment on that? I know you're based up in Auckland at all with the struggles that you're having up that way.
Well, it's just the fact that, you know, general practitioners are being asked more and more to do things for free. And, you know, this whole lockdown period and the next months that follow, we are expecting a real downturn in people coming to us, period, due to unemployment and sub-employment and financial concerns. And it's just another area where, you know, people are, practitioners are not going to do things for free. But, you know, it's, you can't just combine a mental health check in with a well baby visit. That's, you know, that's time. And we all pay enormous amounts of overhead for just to be able to be a practitioner. So, you know, there's a real financial disincentive for doctors to become more involved with things like mental health because it's time consuming. And even, you know, my situation where I see a lot of women and babies that aren't my own patients, but I see them on occasion, and I may only see them once or twice. I certainly am very cognizant of the ones with mental health issues, and they certainly take up a lot more of my time than I would have budgeted. So I budget an hour, and you know, they'll stay an hour, 2 hours. So it is time consuming. And so there's these two issues. You have people that probably have the skills to do a lot with mental health issues in postpartum women, but you know, the hard facts are that we're not getting any funding. And I don't know if people realize this, but I had a discussion with the Ministry of Health a few years ago about the postpartum maternal claim that we can sort of do, you know, for an occasional visit or a one-off visit or something during those first 6 weeks outside of their LMC funding, which we can claim. I think it's $45. But the actual facts are that we're not supposed to be even claiming that unless the midwife is unavailable. So all the funding from the DHBs is definitely, you know, directed towards midwives for those first 6 weeks. So, you know, people still claim this, but in fact, it's, if they were investigated, they need to be able to show that the midwife wasn't available. Not that she's getting her hair cut, but she's actually out of the country, or she's ill herself, or something has happened to the midwife. That's the legality of where we are with funding. So it is a very big issue. And I think until it's resolved, you're just not going to get a lot of GPs doing yet another thing for nothing. It's sad, but it's true.
Yeah, it's totally true. I completely agree. It's a really big problem. And you know, Trina and I, as part of PADA, we went to speak to the Minister for Julianne Genter, didn't we? Minister for Women, and sort of talked about that, you know, just that huge, yeah, there's just so many gaps in that mild to moderate, but absolutely having the funding to actually do any of this, you know, any of the stuff that's in these slides. And I'm speaking to GPs about this in a couple of months, and you know, yeah, that's what, you know, you can just imagine that's what they'll be thinking. Well, I've got a 15-minute appointment and no other funding. How do you expect me to do this?
Yeah, I sort of look at it as they have the one-off pediatrician evaluation that can be done in those first 6 weeks that's funded. It would be good if we had that facility for mental health. And, you know, I wouldn't say that everybody's going to be doing it at all. It wouldn't be everybody's necessarily, you know, their cup of tea or what have you. But if people were reimbursed on the same scale as the, say, the pediatrician, I use that comparison during those first 6 weeks, that you could apply for that at least, even if they put a little barrier that you had to fulfill some criteria. Yeah, it's not that much to ask, really.
No, and if it could be, you know, it could be around just those sort of higher risk and lower income, you know, so that the people who could pay for it could pay for it, but at least those people who couldn't and who potentially most needed it could access the extra funding. Yeah.
Right, good question. Thanks, Yvonne. Good discussion around that. Question from Anna. Would or can a GP signpost parents to a self-employed private service offering therapy that's not offered by the DHB?
Yeah, I mean, we don't really have any DHB options for mild to moderate, so that's kind of the only option. I mean, we have some, you know, so I you know, my experience in Wellington, obviously there are some PHO funded just general counselling things, but in terms of things that people that are specific to mums and babies, you know, we've got no choice but to refer them to community groups or and you know, different people might have different levels of comfort with suggesting private practitioners, but it's really standard. You know, people will often, just in general with mental health issues, you know, I'm looking for a private counsellor or a private psychologist. Can you recommend someone? Who should I go and see? And we'll give people names. Yeah, we'll do that.
And that's part of what we're trying to do as PADA, is create a database of services that do specifically help parents during that perinatal time around pregnancy, childbirth and early parenting. We do have support services on our website based per region as well, but we are wanting to keep that current and just keep adding services to that. So
yeah, and GPs, you know, if they know about it, they could, you know, send the patient a link to the PADA list of services and say, have a look on here. You might find some, you know, you wouldn't want to necessarily just endorse one person and say this is, you know, that could be seen as a bit of conflict or advertising, but certainly to sort of make a suggestion of here's a few names and here's some ideas, or here's a web page which has got a list. Yeah, absolutely.
Yeah, from Anna, she says it's a shame that these have to come at a cost to the parents, as many may miss out, which, you know, is true. A lot of services do offer a sliding scale for counselling services depending on the qualifications of the counsellor as well. But yeah, it seems to be, as Yvonne says.
Yeah, it is an issue. But if it's counselling, we can use WINS. You know, there's a disability allowance, which is to help with health costs, a cost related to a health issue. And so you need to have, obviously, you know, meet the income requirements to be eligible for that. But, you know, you can put as the health issue, you know, I think even stress is one of the boxes you can tick. You don't have to give someone a label of depression. And then you can list the health services they need help with. That could be GP visits, counselling, prescription costs. You know, I think a lot of people miss out on maybe accessing that, and it's probably a bit of a hassle as well. You've got to contact WINS, and they're not always the most helpful. But you know, it does work, and many of my young patients get counselling paid for by WINS.
Great. It's good to have somebody like you, Rona, who takes the time to fulfill that process, you know, to help with their journey.
Yeah, sometimes you just need to know what forms it is and what the system is, and especially new GPs coming to the area might not kind of know which, you know. But yeah,
what's available. Great. Well, it looks like the questions are finishing up. Has anybody got anything else that they need to know? hang in there for another few seconds. No, that's all looking good. So we'll wind up for the day. Thank you, Rona, for your time this morning. You know, it's just really great to know what the processes are, what happens when somebody is being referred to the GP. You know, we often get phone calls or emails from a mum or a dad, or even a worried grandmother, or you know, just a friend about what to do. And we always do say, you know, in the first instance, have they been to their GP? And you know, just what's going to happen once they do go to the GP, what questions they're going to be asked, and how that next process of what the support is available for them. So, fantastic, thank you. So this recording will be made available later on this week, and we look forward to tuning in for next week's pop-up, which will be talking about the Pacifica initiative for pregnant mothers.
Cool. Thank you, Nina. Thanks, everyone.
Great. Thanks, everyone, for your time today.